Imagine it's March 14th, 2019. You are a 44-year-old school librarian living in Columbus, Ohio. Your name is Sandra. You have worked the same job for 18 years. You earn $52,000 a year. Not wealthy, not poor. Somewhere in the solid, quiet middle. You have a small house with a mortgage you're almost done paying. You have $11,000 in a savings account. You have a daughter in her second year of college. You pack your lunch every day. You drive a 2012 Honda Civic with one small dent on the passenger door that you keep meaning to fix. Your life is not glamorous, but it is yours. It is stable. It is something you built slowly and carefully over 2 decades of doing the right things. Then, one morning, you wake up and your chest hurts. If you have ever wondered why one hospital bill can erase everything a family spent 20 years building, stay with me. What you are about to hear is not a theory. It is not a political opinion. It is a pattern documented across decades, embedded in the data, visible in court filings and bankruptcy records, and the quiet devastation of millions of households across the most medically advanced country on earth. It has happened before. It is happening right now. And it always ends the same way. And if you find this kind of historical and financial clarity useful, subscribing takes 2 seconds and keeps you informed. Sandra drove herself to the emergency room that March morning. She was admitted. Tests were run. It turned out she had a partial blockage in one of her coronary arteries, the vessels that carry blood directly to the heart muscle. She spent 3 days in the hospital. She had a procedure. She recovered. She went home. She was grateful to be alive. Then, 6 weeks later, the bills started arriving. The hospital bill was $112,000. Her insurance covered most of it, but her out-of-pocket maximum, the most she was required to pay before insurance covered 100%, was $7,000. On top of that, the cardiologist who treated her was not in her insurance network, even though the hospital was. That physician sent a separate bill for $9,800. The anesthesiologist sent another. The radiology group sent another. By the time every separate bill arrived from every separate provider who had touched her during that hospital stay, Sandra owed over $22,000. She had $11,000 in savings. She was already behind. This video is about one of the most quietly destructive financial forces. It is about how medical debt works, why it is structured the way it is, how it has grown into the single largest category of debt in collections in the United States, and what the historical and economic patterns around healthcare debt actually look like when you trace them back through decades of data, policy decisions, and human consequences. This is not about politics. This is about mechanism. And the mechanism is something you need to understand. Before we go further, there is something important to understand about how medical debt is different from every other kind of debt most people carry. When you borrow money to buy a car, you agree to the price before you sign anything. When you take out a mortgage, you know the numbers. You choose. You negotiate or you walk away. Medical debt does not work like this. Medical debt is often incurred at the moment of maximum vulnerability, when you are unconscious, when you are in pain, when you are terrified, when someone you love is dying and you would agree to anything if it means they survive. The transaction happens without your informed participation. The price is not disclosed before the service is rendered. The bill arrives weeks later, itemized in a language designed for billing departments, not human beings. Think of it like this. Imagine you are driving through a dark tunnel and someone pulls you over, fixes your car, and then mails you an invoice 3 weeks later for an amount they calculated using a formula you were never shown based on a price list that changes depending on who is asking and why. That is what receiving a medical bill is often like in the United States. The service is real. The need was real. But the pricing system was built to extract, not to inform. This structural asymmetry, the gap between when you need care and when you learn its cost, is the root cause of the crisis. It is not an accident. It is the product of decades of policy choices, hospital consolidation, insurance complexity, and a billing infrastructure that grew more sophisticated faster than consumer protection laws. And the result is a debt load so enormous that it has become the financial equivalent of a slow flood, rising quietly in millions of households until the floor gives way. The numbers are staggering and they are real. According to a landmark study published in the American Journal of Public Health in 2019, 66.5% of all personal bankruptcies in the United States cited medical issues as a contributing cause. That is 2 out of every 3. Not credit card spending, not failed businesses, medical bills. A separate analysis by the Kaiser Family Foundation from 2022 found that roughly 100 million Americans, nearly 1/3 of the entire adult population, carry some form of medical debt. Of those, about 14 million people owe more than $10,000 in medical bills. The Consumer Financial Protection Bureau reported in 2022 that medical debt accounted for more than half of all debt that appears on credit reports and collections. More than half. Not student loans, not car loans, doctor bills. This brings us directly to the first historical pattern in this story, because what is happening in America today did not emerge from nowhere. It has a history. And that history shows something deeply uncomfortable about how a healthcare financing system, once it reaches a certain level of complexity and opacity, begins to function less like a safety net and more like a trap. In the early 1980s, the United States government made a series of decisions that fundamentally changed how hospitals were paid. Before 1983, Medicare, the federal program that pays for health care for Americans over 65, reimbursed hospitals based on what care actually cost, line by line, procedure by procedure. If a hospital spent more on a patient, Medicare paid more. There was little incentive for efficiency, and costs were rising fast. So in 1983, the government introduced a new system called diagnosis-related groups, or DRGs. The idea was to pay hospitals a fixed amount per diagnosis, regardless of how long a patient stayed or what specific treatments were used. It was designed to control costs. What actually happened was more complicated. Hospitals quickly learned that to survive financially under this new system, they needed to specialize in the procedures that paid well and minimize the ones that did not. They began developing what economists later called the charge master, which is an internal price list with hundreds of thousands of line items, each priced at rates far above what any payer actually paid. The charge master was not designed for patients. It was designed for negotiation, a starting ceiling from which insurance companies could bargain down to contracted rates. Uninsured patients had no negotiating power. And no knowledge of this system, they were often billed at full charge master rates. By the mid-1990s, the spread between what insured patients paid and what uninsured patients were billed had grown into a canyon. In 1998, a 41-year-old self-employed electrician named Dave Dobbins in Phoenix, Arizona, was hospitalized for 12 days with pneumonia and kidney failure. He had let his health insurance lapse 6 months earlier when a small business contract fell through and he could not afford the premiums. His hospital bill was $238,000. He owned a small house and a truck. He filed for bankruptcy within 8 months. His case was not unusual. It was one of tens of thousands that year alone, but it illustrates the mechanism perfectly. The uninsured patient received the same care as anyone else. He was billed at a rate that bore no relationship to what any insurer would have paid for the same stay. And the debt he carried was not a debt most humans could survive financially. The underlying economic force here is called price opacity, which means that prices are hidden or unknowable before you buy. In almost every other market, price opacity is regulated. In American hospital care, price opacity became structural, baked into the billing architecture, protected by complexity, and reinforced by the fact that patients cannot shop around. Here is something I want you to think about before we go further. If you or someone close to you has ever received a medical bill that seemed impossible to understand, that listed charges in codes rather than plain language, that arrived from providers you did not even know had treated you, can you remember what it felt like to try to navigate that alone? Drop your answer in the comments. Seriously. Because what I am about to show you next is the part of this story that most people never hear. It is the part about how the debt collection ecosystem around medical billing evolved into something entirely separate from the original healthcare system, and it changes everything. When hospitals began operating under tighter margins in the 1990s and early 2000s, many of them began selling unpaid medical debt to third-party collection agencies. This is the same process that happens with credit card debt, but there is a crucial difference. Credit card debt is incurred deliberately and with full knowledge of the terms. Medical debt is often incurred without consent, without a disclosed price, and often from people who had no alternative. The debt buyer purchases overdue accounts at a fraction of face value. By 2005, a small number of large companies had cornered the market on medical debt purchasing. One of the most significant was a company called Accretive Health, later renamed Aspirion, which operated collections departments embedded directly inside hospital systems. A 2012 investigation by the Minnesota Attorney General's office found that employees were approaching patients in emergency rooms and asking for payment on old debts before patients were seen for new treatment. Not after, before. People lying in emergency rooms were being asked to resolve bills. When this story broke nationally, it became one of the most widely cited examples of how profoundly the medical debt collection apparatus had departed from anything resembling patient care. But the collection practices are only one layer. The deeper mechanism involves credit reporting. Until very recently, medical debt appeared on credit reports the same way credit card debt did, with the same weight, the same scoring impact, the same ability to block access to mortgages, car loans, and rental housing. A 2014 study by the Consumer Financial Protection Bureau found that medical debt on credit reports disproportionately harmed consumers whose overall credit profiles were otherwise healthy. In other words, people who paid all of their other bills, who had never defaulted on a loan, who had done everything right, were being blocked from the conventional pathways to housing and economic stability because of a hospital bill. The impact on housing is not abstract. A 2021 study by the Urban Institute found that in counties with higher rates of medical debt, home ownership rates were measurably lower, even after controlling for income, employment, and education levels. Medical debt was acting as a specific suppressor of wealth building, a weight placed on millions of households. This leads to the second part of this story, and a historical case study that sits across an ocean in several decades, but contains the same mechanism written in a different language. In the United Kingdom in the 1980s and early 1990s, a wave of National Health Service restructuring took place under the government of Margaret Thatcher and her successors. The NHS had been built in 1948 on the explicit principle that healthcare should be free at the point of use for every citizen regardless of income. But cost pressures led to internal markets, which meant that NHS trusts were required to function more like businesses, buying and selling services from each other and competing for funding based on efficiency metrics. The consequences were complicated and deeply instructive. On one hand, some inefficiencies were reduced. On the other hand, hospitals that served poorer populations found themselves underfunded relative to the cost of the care they were providing. The funding formula rewarded throughput, moving patients quickly, not complexity, which is what the poorest communities actually needed. This created what economists called cream skimming, where the incentive was to attract the cheaper, easier patients and avoid the expensive, complex ones. The British experience matters. It demonstrates that medical debt crises are not uniquely caused by the absence of a public health system. They are caused by the intersection of healthcare complexity and opaque pricing. Inadequate financial protection at the point of care, and collection or cost-shifting mechanisms that place the weight of that complexity onto individual patients. The mechanism can operate anywhere. By 2013 in England, NHS trusts collectively ran a financial deficit of around £250 million. By 2016, that figure had grown to nearly £2.5 billion. Patients were increasingly experiencing delayed care, discharged earlier than ideal, transferred between facilities in ways that generated additional costs and denied treatments. Families caring for relatives with chronic conditions found themselves absorbing costs that the public system could not fully cover through lost wages and home modifications. The debt did not appear on a hospital bill in most cases, but it appeared in household budgets. It appeared in retirement accounts depleted to cover care. It appeared in financial wreckage. Now, here's where it gets interesting, because the American and British experience point to a third case study that is arguably the most extreme example of household-level breakdown. Brazil between 1990 and 2005 went through one of the most dramatic healthcare financing collapses in the history of any major democracy. The Constitution of 1988 guaranteed universal care. The Unified Health System, known as the SUS, was created to deliver it. But the system was chronically underfunded. Private health plans emerged to fill the gap for middle-class Brazilians. What happened next was a masterclass in how insurance complexity combined with weak regulation produces household financial catastrophe. Private insurers developed predatory practices. Plans would accept premiums for years from customers who were young and healthy. When those customers developed serious illness, the plans would reclassify them or raise premiums dramatically. People who had paid into their health plans for 15 or 20 years found themselves uninsured at precisely the moment they needed care most. The results were measured in ruin. Between 1995 and 2002, medical costs contributed to financial ruin in somewhere between 30 and 40% of lower middle-class household collapses in urban Brazilian areas. People sold homes. People liquidated the education funds of their children. People borrowed from relatives and exhausted those relationships permanently. The debt itself was bad enough. But the social cost, the fracturing of family networks, the isolation of the sick, and the shame attached to financial failure was perhaps the more lasting damage. Most will never know this. Most people will keep believing that medical debt is an edge case, something that happens to people without insurance, or people who made bad choices. But the data shows something different. It shows a pattern that crosses political systems, crosses income levels, and crosses the line between public and private health care. If you are still here, you are not most people. Hit subscribe. Because the next section is the part this channel was built for, the part where the pattern becomes impossible to ignore and the human cost becomes impossible to look away from. Now observe what all of these cases have in common. In the United States, it was pricing opacity and collection infrastructure. In the United Kingdom, it was cost pressure transferred invisibly. In Brazil, it was insurance complexity weaponized against the sick. Different countries, different systems, different contexts, but the same underlying structure and the same result. The rot was not in any single policy. The rot was in the relationship between complexity and vulnerability. When the system becomes too complex, the outcome is predictable every single time. The fourth major pattern in this story connects directly to who pays the highest price. This is where history gets uncomfortable because the data is unambiguous about the answer. Medical debt does not fall evenly. It does not strike at random. Its weight is distributed with a precision that mirrors the existing structure of economic inequality and then amplifies it. It pushes down those who are already below, and it protects those who are already above. In the United States, data showed 37% of black adults reported carrying medical debt, compared to 26% of white adults. Adults without a college degree were significantly more likely to carry medical debt than those with one. Income is a massive factor. Adults earning below 200% of the federal poverty line were more than twice as likely to carry significant medical debt. This describes a system that extracts from the weakest.